We'll start the presentation. I'm going to give it a minute, open it, and just want to let you know that I am going to open the presentation live, and we'll get started. And Amy, give it a second or two, and then you can start your welcome.
Okay.
Great.
The broadcast is now starting. All attendees are in listen-only mode.
Welcome, everyone. I'm Dr. Jeannie Alter, and I serve on the Board of Directors for the American School Health Association. Thank you for joining us for this first of a two-part webinar series that is exploring research on youth and adolescent obesity. These webinars are an exploration of the applications of research appearing in the March 2013 issue of the Journal of School Health. The American School Health Association is proud to partner with the United Health Foundation for this important discussion of a critical and complex issue facing our young people. The American School Health Association is a multidisciplinary association of approximately 1,000 individuals. ASHA's mission is to build the capacity of its members to plan, develop, coordinate, implement, evaluate, and advocate for effective school health strategies that contribute to optimal health and academic outcomes for all children and youth. We are the proud publishers of the Journal of School Health, a premier journal area of school and adolescent health. If you are a member of ASHA, you can elect to receive a hard copy or electronic copy of the journal. The price of membership is inexpensive, and for the price of admission, you receive the journal, access to our blog, and free continuing education hours. I hope that you'll consider joining, volunteering, and becoming a member of the ASHA community. For continuing education today, we are asking for $30 from non-members and offering continuing education at no cost to members. After the webinar, you can receive 1.5 hours of CEs for 70% or more participation today. Please take a look at the archived webinars also available on our website. And please join us for, please join us October 9th through 12th for the 87th Annual ASHA Conference in Myrtle Beach, South Carolina. It will prove to be a wonderful conference, and we sure hope to see you there. ASHA is thrilled to partner with the United Health Foundation to bring you this webinar series. And I'm pleased to introduce Shelly Espinosa to say a few words about the United Health Foundation. Shelly?
Great, thank you, and welcome everybody, and thank you for participating on today's webinar. I'm Shelly Espinosa with United Health Foundation, and we're really excited to support this webinar series as well as the special journal issue, which hopefully all of you have had a chance to take a quick peek at before today. United Health Foundation is a private foundation that's solely supported by United Health Group, and to our work around childhood obesity, we also focus on access to quality health access to quality health care through community health centers and future health workforce development. A lot of that focused on providing scholarships to minority students who are pursuing careers in health. And we're just super excited to be a part of this, and looking forward to the presentations ourselves and to hearing what kinds of questions and dialogue come up afterwards.
Thank you, Shelley. I want to introduce Dr. Anjali Jan, who will be facilitating the webinar and is also our first presenter. So, Dr. Jan.
Hello. Good afternoon, everyone. Well, it's afternoon on the East Coast anyway. Thank you very much for joining us today. We're very happy to be here. I'll say a couple words about who I am. I'm a physician and health services researcher that with the Lewin Group, and the Lewin Group is a independent research and policy health organization located in the Washington, D.C. area. That's a subsidiary of the United Health Group, but is editorially independent. And so I did part of this project in my capacity as an obesity researcher, as well as part affiliated with United Health Group and United Health Foundation, therefore. So I will be talking a little bit about the project that we undertook and some of the early results from that project. I wanted to go ahead and introduce my fellow panelists, and they'll be speaking about their individual studies and articles in this special issue afterwards, and there will be time for questions. So actually we'll have a few minutes for questions at the end of each presentation, and then we'll have a longer period of time at the end for questions for any individual or all panelists combined. Is there any? Oh, you can type them in to the webinar. There's a little window there. It should be on your bottom right. That's where it is on my screen anyway. And those typed questions will be handed to me as they come in, but I might end up saving them so that they can be asked as a group depending on the content. Are there any questions? Okay. So after me, we will hear from Dr. Carol Bryant. And we're very privileged to have her with us today. She is a distinguished professor at the University of South Florida. And her background is in anthropology, or her degree is in anthropology, but she's done quite extensive work on social marketing research, particularly applied to public health projects. She's developing and evaluating an innovative framework called community-based prevention marketing for designing and tailoring behavior change interventions and promoting policy change. In addition to research, Professor Bryant teaches a variety of graduate-level social marketing courses and coordinates annual social marketing and public health conference, social marketing training academy, and online social marketing certificate. So we'll be hearing from her both about social marketing applied to this issue in general, as well as her particular project, which is quite innovative. After Dr. Bryant, we'll be hearing from Dr. Jordan Carlson. He's the biker in the photograph. And he is a postdoctoral researcher at the University of California, San Diego, and part of the active living program there that's generating a lot of studies and publications that are really at the cutting edge, I would say, of physical activity research, and including the influences on the built environment, et cetera. Dr. Carlson received his PhD in public health from University of California, San Diego, and he's currently, I believe, in his 4th postdoctoral year. And his research is designed to inform policies to improve physical activity opportunities in schools and in neighborhoods and at a community level. So we're quite fortunate to have both of them today. I will go on to talk a little bit about our project in just a minute. Okay, so this is the collaborative school-based obesity interventions, lessons learned from 6 southern districts. Okay, so as in way of background, schools, as we know, have been identified as favorable environments for childhood obesity interventions, mostly because so many children go to school, and nearly all children in the U.S., as well as they're in school long enough that they actually have opportunities to both learn about and practice behaviors and health relevant behaviors. However, there's quite a few challenges with working with schools. Schools already are under very intense resource constraints and function as pretty complex bureaucracies that often differ from setting to setting. Because of this and because of all the many variables that take place during the school year and the school day itself, schools can be ill-suited for actually evaluating interventions to understand what works and what doesn't work. Overall, little is known about how to translate and sustain school-based programs that have shown promise in idealized settings such as research studies into real-world situations. So we put together a program called Activate for Kids, or AFK, and we implemented this program in 6 school districts and over 100 schools. This paper is reporting on the progress that was made between 2011 and 2012, but it is ongoing currently as well. So this included the overall design of the program initially, which did change throughout the intervention a little bit, which I'll talk about. But the monitoring and oversight were at the leadership level between United Healthcare, United Health Foundation, and collaborating with the National Association of School Nurses. The monitoring and oversight at the local level was more at the district leadership level, including the superintendent and the district administrators. The program itself was really designed around 2 change agents, as we call them. One is the school nurse, thinking the school nurse is ideally suited to be located within schools, but also dedicated to health issues within school setting, as well as a wellness coordinator. Now, there was only one wellness coordinator for each school district, but worked very closely with the school nurses, and for the wellness coordinator, their sole charge was around obesity-related activities and treatment and prevention. The program itself included several components with some flexibility at each setting and site. One was BMI screening and parental notification. The second was something called scope training, which was school nurse childhood obesity prevention education. This was a classroom module of training around obesity, how to measure it, what is it, what kind of consequences result from obesity. There was also the opportunity for micro-grants for individual smaller-based projects that the schools and school nurses could apply for. There was ongoing funding support for activities at the school level, at a higher funding level. And there is also the opportunity to refer children who are obese and overweight to clinical resources and interventions with the JOIN program, which was a particular program that was supported by this effort as well. So this is a busy slide, but it just shows you, I think, very nicely how many players are really involved and why these interventions themselves, as well as the flexibility needed, is so complicated. The school nurse and the wellness coordinator are really at the center. The funders you can see on the left, and more of the leadership and overall design. But what ended up happening, which I think many can relate to, is that it really came down to the school nurse, the wellness coordinator, the students, the parents, and the teachers at individual schools to really make this work. So for this article, we did semi-structured interviews with 19 key informants last spring, and these included wellness coordinators, United Health Group and United Health Foundation project staff, school district administrators, school nurses, as well as some parents and children who were participated in the JOIN interview. So the questions included questions about what their perceptions were around the status of school wellness policies and any changes that seem to result as a result of the Activate for Kids, the effectiveness or the perceived effectiveness of the various components of the initiative, some of the facilitators and the barriers that arose during the course of the intervention, or at least the first year, as well as some of the changes that may have resulted in the responsibilities and the mission and the engagement of the community and or the participants as the initiative progressed. So we had a lot of results, but I'll touch on a few, and hopefully we'll have a good discussion afterwards or after all the presentations together. So there were quite a few challenges, but also what ended up happening is that because the needs and the enthusiasm and the interest were different at the district, among the many districts, as well as at particular schools, often the intervention itself took on a different shape depending on locale. But overall, people perceived the intervention as being quite successful, and this was sort of mentioned as there were more wellness activities than there had been in the past. One thing that was quite enlightening, I think, is that even though there were already existing funding sources for activities, somehow this initiative, through the work of the school nurses and the wellness coordinators, were able to really pull some of those dollars together. So amplifying the resources available for obesity-related activities. The school and district level wellness committees formed and met more frequently as a result of this intervention, and the improved sharing of information and strategies among the peers during the course of the year seemed to improve markedly. So one thing that we realized is that traditionally school nurses often have worked in quite a bit of isolation. And so the presence of the wellness coordinator as well as the shared area of work really allowed a lot more communication among nurses as well as support for each other that seemed to be related to this particular initiative. Now the nurses there was quite a bit of variation among the nurses in terms of how much effort they could really dedicate towards obesity-related activities or the Activate for Kids program. But there were certainly instances of nurses really going above and beyond, demonstrating extraordinary effort and commitment, and leading and really sustaining new wellness activities. They got really excited. Some of the other perceived reasons for some of the variation was the varying support from the district leadership for the particular nurses, or often even for the wellness coordinator themselves, as well as just individual personalities and education level. There was one comment that the nurses that were more highly educated seemed able to more to get interested as well as to dedicate more resources to obesity prevention activities. That was the view of one of the key informants, however. It wasn't really proven by data. Barriers certainly include things we know about, lack of time and compensation, competing responsibilities. There was a real fear of grant writing. Perhaps it was a mistake to even call it a grant writing. Often these micro-grant applications were just a page or two long, but nurses who had not done that kind of thing before really felt quite inexperienced and unable to put together that effort, but with the wellness coordinator often were quite successful. There was also no consequences or repercussions for not participating, and certainly in one of the school districts that we worked in, there had just been a huge number of layoffs of school nurses themselves, and so there was definitely reasons not to be motivated to take on one more thing for the nurses themselves. At the bottom is just a quote that we've found that some of the quotes in the interviews really kind of told the story. So this was from a school nurse: to persuade and encourage others also to join into this health initiative, especially those who already feel overwhelmed with daily obligations, responsibilities, and expectations, is difficult. So some of the lessons we learned, overall vision for the program had to be quite flexible and customized according to the culture and the concerns and interests that were very local. This also makes it much harder to come up with evidence and to show what's likely to work and what isn't, or to demonstrate impact. Even programs that were free or completely funded by United Health Group and Foundation and the collaborators involved had hidden costs, in a sense, that they still required time and commitment at the district or school level. And so without some of those other supports, they may not be attractive. This is a quote from a district administrator. There's so much that schools want to do, but don't know how or don't have the resources to do. Activate for Kids is about providing assistance in how to organize, develop, and get resources for wellness programs. And very early on, we learned, in even those initial conversations with the districts, we learned that this couldn't be our program that we're forcing on them, but it had to become their program, and we were there to help them design the program that they wanted. So one of the ways we did that, for instance, is the wellness coordinator that was funded, whose salary was funded through United Health Group, was only local candidates were considered for that position. So I think that gave them a real head start in being able to initiate activities because they were already comfortable and familiar and had connections and networks within the school setting or around the school setting that they could draw upon to really get going quickly. Some other lessons we learned were that the classroom training, such as SCOPE, were useful, but not really all that practically helpful in terms of what the nurses were facing with and in knowing how to talk to their leadership, work on policy level changes, or even come up with community resources to refer patients who are at risk, et cetera, or students who are at risk for obesity or are already obese. So the availability of practical interventions, such as the childhood obesity intervention join that I mentioned, that seemed to be very motivating because the nurses not only identified a child who was obese or overweight and had some risky behaviors, but actually had somewhere to send them to. And it did seem to be those individual stories and successes that really motivated both the nurses as well as the families and people at the community level to keep going with a program like this. Having a single person, in this case a wellness coordinator, dedicated to obesity seemed very critical, so that even when there were competing responsibilities for the nurses, for the district, that wellness coordinator could kind of carry the charge through those times. So here's a quote from the wellness coordinator, one of the wellness coordinators. They needed someone to do the legwork and be the motivator. They had all kinds of ideas that they wanted to do, but had no time to do it. So I helped them, and now it's contagious. The school is involved, and it's so much more. And that's really what we were looking for, is the school to take it on and run with it. You know, all along the way, we've had a lot of questions as well as concern ourselves about, okay, what happens when you guys go? And so the idea of this program is to really make it something that fits the schools and schools that they want to then take on and don't necessarily need outside encouragement to go forward. Okay, well, we'll take a minute or two for questions, and then go from there.
And at this point, if you have questions for Dr. Jan, you can type them in on your screen where it says questions, and we can interact that way.
All right, I have a couple questions that I'll try to answer, and I might call on you, Shelley, to help me out a little bit. So question number one, what are the next steps, and what have we learned about sustainability? Shelley, do you want to take a stab at that?
Hang on, I think she's muted.
Sure, I can try.
Okay.
And having not kind of being the program manager on this one, but you know, based on feedback that I've heard from the program manager on this one, I think clearly United Healthcare and United Health Foundation are committed to keeping the work going. I think what we learned is that it also took us a while to get things off the ground. There's a lot of different relationships involved in making a program like this successful, and spending the time up front to build and develop those relationships is really important. So I would add, if others are considering doing this kind of work, that relationship piece is really key to getting the buy-in that's needed, both at the very top levels, but also from within the districts themselves, and then getting that commitment so people stay engaged and committed to the process along the way.
Yeah, and if I remember correctly, at the beginning, we had talked to several districts that ended up not really being able to commit to come up with this final 6. So I'm having another question here. How is the wellness coordinator funded? So the salary of the wellness coordinator is supported by United Health Group. So they're actually an employee of United Health Group, but they work locally. So that's how that position was funded. We committed at the outset to at least a year of funding, and now we are have committed to the 2nd year as well. There's another question: what was the socioeconomic status of the schools you worked in? So it was generally middle class, although there were certainly some schools that were in the lower socioeconomic status. Not many in the upper ranges. In the paper itself, there is a chart that delineates the some socioeconomic status markers of the 6 different school districts, such as, I think it's average income, as well as some race and ethnicity data there. We've purposely picked southern districts because of the high rates of childhood obesity, and in fact, some of the school districts that we worked with have very high rates of childhood obesity. Okay. All right, so why don't we move on to Dr. Bryant's presentation?
Thank you very much. It's really delightful to be here with you today. I want to begin by thanking the organizers for teaching me how to do this, or at least getting me started and offering to help me. As I told them, I'm not real familiar with this and will colonoscopy than do a webinar. But they've reassured me that they'll hold my hands. So it's a delight to talk to you today about an innovative planning model called community-based social marketing. And we'd like to start by finding out from you which of these objectives would be of greater interest to you, so I know which portion of my presentation to emphasize today. Are you more interested in learning how you could use social marketing to design a program like I'm going to describe to change people's behavior? Or are you more interested in the Scorecard program, which I'm going to use to illustrate that model and that the journal article described? So if you would send the organizers your answer, whether you'd rather have me focus on social marketing, the Scorecard program, or equally spend time equally on both. And they're going to give me the answer before I go on. Well, while we're waiting, let me at least tell you the ingredients for the community-based prevention marketing, which we call CBPM. It has to do with combining, in a way, like a blending of community wisdom and ownership to bring about behavior or policy change. And today I'll focus on a behavior example, but we also have worked in the other arena. And, of course, the ingredient we are adding is the use of social marketing. So let's hear from some of the organizers now. To that poll?
So we do. We have some early results here.
Okay.
So it looks like about 2/3 are interested in how social marketing can design behavior change intervention, and 10% or so are interested in how the Scorecard program works, and a third have, or 27% say no preference.
Okay, that is very helpful. So I will focus, I'll give all three segments of this audience something, but I'll focus on the social marketing. Okay, so let's get going. I'm going to sort of break up this model and talk about the three pieces, and then I'll really tell you about what social marketing can do for you. So the first part of this is honoring local wisdom and getting the community actively involved in designing the intervention. And this is a picture of the coalition in Lexington, Kentucky that designed the Scorecard program. And our role from the Florida Prevention Research Center was to teach this group of people how to think like a marketer would in designing a strategic plan and then implementing that plan to bring about behavior change. You can use this to do, like we did with Scorecard, to take a population, understand it, and design an intervention, say within the school setting or for parents of the kids in that school as your population, and design a program to get them to change their behavior. Or you can do this to get policymakers to change the policies. That could include a school board. It could also include organizational procedures, like what a school might have as its policy on using foods as a reward, or what they sell in their snack shop. Now, let me tell you about the social marketing that we think will really help a community do this better than if they just sat around a table and used their creativity and their great understanding of their local community. First, I'm going to talk about how a marketer takes a population like school-age children or parents and divides them to understand subgroups or segments within that, and then pick one or more of those to give the greatest priority in the planning. And I'll talk about why that's so important. What I hope you'll take away from this more than anything is social marketing's passionate commitment to think like the person you're trying to change, to crawl inside of their life, to understand what it's like to be a middle schooler today, to understand what it's like to be the parent of a middle schooler, how you do that, and why that insight is so powerful and can change from top to bottom how you approach program planning. And then I'm going to share very briefly marketing's conceptual framework and how it will help you create a strategic, well-integrated plan. So audience segmentation first. This is a fancy way to say not everybody is the same in your school-age population, in your community, or among the parents. And that it's really worthwhile to take time to understand the different pieces of this population and to assess which of those segments you can really reach with the resources you have available right now, and to decide which of those will be most likely to really benefit from your efforts and perhaps are the ones that can model the behavior to others. And I used to be Deputy Commissioner for Nutrition and Health Education in Lexington for many years, and I sure wish I had known more about this then, because we always just said, well, let's have one program and it should work for everybody, and then we'd scratch our head and say, well, gee, how come those people came in, the others did not? This is the answer to that question. Consumer orientation is how you make that first decision by talking to different representatives from the different part of the population to see what they want, what their needs are, and to decide which of those are most likely to respond to a program that you can afford to mount. So consumer orientation is really marketing research or consumer research. It's interviewing. And by the way, this is a doctoral student interviewing the editor of your journal. on the left, Robert McDermott. You could do focus groups. You could also, of course, just do key informant interviews. But what you're listening for are the answer to questions. This is going to be practical data that answers these questions. First of all, what are you going to promote? That actual product, is it a behavior? Is it a policy goal? What exactly do you want people to do differently? We already talked about the second decision, which is which segment or segments you're going to give the greatest emphasis to as you plan this intervention. For those groups, what are the benefits that they value the most? Of all the things that they could want, what could you give them that would really make them do it? Do you need a tangible tool to help them do that? A monitoring device, an 800 hotline? What service could help them change their behavior? And what could get in the way? What do they give up? What other barriers, what other fact impede their adoption? And then where do they adopt this behavior? Where are they when they make those decisions? And who's there? Who could partner with you to facilitate change at the right time and place? And finally, and I want you to notice it's the last piece of this table because it's the last thing we talk about, think about, and probably the least important, and that's the promotion. That's the fancy messages and materials. And they just won't work if you don't have them integrated into a plan with those other points already made. So let me now take us back to Lexington. This is the other part of the community for that project. These are high school students who we hired and trained to be our market researchers and to speak for the kids because that larger coalition had picked children as the population that they wanted to work with to prevent obesity. Okay, first step. The coalition set goals for preventing obesity, and they use their BMI data that they collect through school nurses in 6th and 8th grade, and they decided that most of those kids, especially girls, were starting to pack on the extra weight as they moved through middle school. So they picked as their segment and as their behavior to approach tweens. Those are kids between childhood and teenage years. They're about 9 to 12. And so that's the target segment population. We know that boys and girls are slightly different, and we have to honor that in our efforts. But we don't want to just pick one. We're going to do both. And they picked getting them not to gain extra pounds during this critical period through physical activity. And without a lot of time, this was a month-long process to pick physical activity over other behaviors. And that's because they figured they had much greater chance with very limited resources to get kids to be active as opposed to try to change parents' behavior and all of that. It's just changing parents and getting them to model would have been perfect, but almost impossible. Now, this is the coalition interviewing parents and those tweens once we know who we want to understand and what we want to understand would motivate them to be physically active. Those insights went into creating this marketing plan. So you can see how we answered those generic questions with data to decide that the best way to get tweens moderately to active or sedentary, tweens, to play. Notice that we didn't say exercise as the product we're promoting, and that's going to become more evident in a minute. But thinking of tweens, they're not nearly as interested in exercising as they are in having fun and playing. So the core product, or the benefits that we were going to offer them, that our research showed would make them be more active, especially in the summer when many of them are stuck at home while their parents are working. Those benefits would not be prevention of obesity. They would not be preventing awful diseases in 35 or 40 years or 60 years. It was something valuable right here, right now. It was have fun, play with your friends, and try new things. Now, we felt there was a need for a tangible product, and that we called a scorecard, and I'll show it to you in a minute. It's a monitoring device because kids in this tween demographic of counting things up and keeping score and getting recognized for achievement. Now, the way we were going to position this product of playing so it would be better than the competition was to make a program that would make physical activity more fun and more exciting way to spend time with friends than what they're doing now, which is staying home and playing games on the video, watching TV or other screen time. We recognized after our research that in order for this to happen, even if they were motivated, they had to try things that are easy to do, non-competitive, safe, and inexpensive. Parents aren't going to let them do it if it's not safe and they're not supervised. They can't afford to let them do it, especially if we want to get the lower income families involved, if there's a fancy uniform or it's really expensive. It's got to be easy and not competitive because at that age, one of the worst costs you can pay is to be humiliated and to fail. And so we all took sort of a pledge that we would make it fun and we would not put together a package that was too expensive, either as a threat to their self-esteem by humiliating them or having them try out for a team that they didn't make. But everybody could play. And then we knew that at that time, this started in 2003 and has been running up until just about a year ago in Lexington, and I'll talk more about how it's scaled up nationally. But we realized that the key here was this placement piece of our plan. We had to create opportunities or action outlets all over town during the summer where they could go and be active in a way that was safe, inexpensive, easy to do, and tons of fun. So VERB campaign was airing at this time, so we called it the VERB Summer Scorecard Program. And 80% of the kids we talked to in Lexington knew about VERB and thought that was cool, but they didn't know where to go. So we realized, what can a coalition do that doesn't take a lot of money? They can create opportunities through their social networks all over town where kids can go and have a heck of a lot of fun. Now, promotion here was not very important. We gave them a chance to win prizes. We participated in special events, and that card got them into all kinds of fun things. 2 for 1, free skating on Saturday nights at certain places, and so on. But really, it was knowing what will make these kids love to do this that was the ticket to success. And it was this. Here are 3 girls in the scorecard program having fun. They could go to the public school pools, which used to cost about $8 for the family to get in, and they could go free with their parent if they had a scorecard, and they could take their friends. Here's the front of the scorecard, and take a look at it. Do you see a health department logo? Do you see the name of the coalition and sponsors? No, you see fun, great deals. It's consistent with the marketing plan. So whatever promotion you do have needs to be integrated with your product promise. Now on the back of this scorecard are 24 squares, and children got to check off or get stamped a square when they tried something new and were physically active for about an hour. A parent could fill out about half of these. And then all over town, churches sponsored events that they stamped, laser tag, and so on. They just had to get 24 of these filled before they were eligible for prizes. And the deals were almost all offered by businesses, neighborhood associations, the local university, people a coalition can recruit that a university like where I'm located simply can't do it. Now, to lower the cost, like I said before, we made sure everybody could participate and everybody could win. And they could go locally, like down the street to their local church, and many churches did like this Baptist church, bought fun activities for tweens in their neighborhood and were able to recruit using their parishioners as volunteers to be sure the program was safe. On the longest day of the year, longest day of play, there were 13 organizations that offered action outlets. And at the end of the summer, the local baseball stadium was opened up to all the kids that had completed or almost completed a card. And they could finish it off at 21 different kiosks where they tried different forms of activity, the most popular being this one. It's the radar race, where the police brought their radar guns and figured how fast these kids could run. They could try baseball, and then they all went into the bleachers with their cards submitted to win prizes. This is the winner of the grand prize. He could pick from a selection of things donated by local businesses, and he picked free karate lessons for a year, which he'd always wanted to do, and he had to stop because of the cost. But everybody was a winner, not just our 10 grand prize winners. Everybody got a backpack with all kinds of physically active, appropriate gifts stamped with the Verb logo. And they all ran the bases on a wonderful August night in Lexington. So how'd the program work? Well, the first year during our pilot was very successful. We learned a lot of lessons and made some changes, but we, over time, monitored it, and we've noticed a relationship between awareness about the program and increased physical activity, intention to participate in the future, and over 25 communities around the country have adopted it, including Sulphur Springs Elementary School in Tampa. But most importantly, it impacted our target behavior. And the article that you have in that special issue talk about the relationship between participating in the Scorecard program and the frequency of physical activity as measured in a survey done in middle school. And we found that particularly girls reported that participation in Scorecard made them more likely to be moderately active and less likely to be sedentary. So I hope what you've taken from this is that community-based prevention marketing capitalizes on local wisdom and honors community ownership of a program so that it can be sustainable and you can harness that incredible power of a coalition. There's no way overnight we could have created 100 action outlets all over town in just a few months. You can use this to focus on a behavior change program like I talked about today, or if you want to know more, email me and I'll tell you about what we're doing with that same coalition to change the policy environment and make healthy food now more accessible wherever you go to school or play in Lexington. And our contribution from the University of South Florida's Florida Prevention Research Center is our expertise in marketing, which I think you could see would be powerful in making it systematic and sustainable. If you want to know more about implementing a Scorecard program, you can download this manual. It'll tell you everything from how to recruit your coalition to how to put together the monitoring device. And if you can't get this website easily, email me or just Google Verb Summer Scorecard and you'll find your way to it. If you want to learn more about social marketing, we have a conference and training academy in 2014. We're not going to have it this summer. We're now going to go to every other summer. We also offer a 5-course graduate online certificate program. And we have a website with training materials and many publications about what we're doing. So I'm going to open it up to questions now.
Hi, Dr. Bryant, this is Dr. Jan. I have a question for you. So is this social marketing approach based on or adapted from what professional advertisers use to get children and adults to do a lot of things that are unhealthy? Or are the principles kind of different?
The principles come from marketing, but yes, marketing has been used for a lot of by a lot of the industries that we are now using marketing to oppose. My work started out with breastfeeding promotion, and our opponents were a well-funded formula industry, and they were always a step ahead of us and were very upset when we discovered secrets to their success and used them to fight back. And this time, of course, we're fighting against a well-funded food industry that markets to our children and has gotten us into this mess.
Mm-hmm.
Yeah. So those secrets are audience segmentation, research to really understand the people you're trying to change, and many of the insights that we got for this project came from their literature on kids, because tweens spend so much money, not only their own allowance, but their relatives' money, that they nag us into buying things for them.
From the audience? Oh, I'm sorry. I was on mute. So here's a couple questions from the audience. One, actually two questions are about cost. So what does it cost to design or a program like Scorecard or to replicate it?
We have worked with quite a few communities, and of course they, like Lexington, didn't have much cash to put into this. What they had was a lot of volunteer time from people who would be on the coalition. So out-of-pocket costs, you could do this for less than $5,000, especially in today's world, because that scorecard doesn't have to be printed any longer. Lexington's initial high-cost item was creating 10,000 of those scorecards, but now those are downloaded off of the internet, and so they're relatively inexpensive to do. You just design them. So that was the big ticket item that now is very inexpensive. The other costs are to create a calendar of events to give parents, but again, that's more a design and graphic design cost. And if you download our manual or ask for our help, we can help you use the graphics and the guidelines, and so that can be much less expensive. So it's really doesn't take a lot of grant money to do one of these. Mm-hmm. And in a school setting, it can be even cheaper because you can use a lot of school resources to do it.
Has the scorecard itself been used within a school setting?
Yes. Our experience here in a very economically challenged community working in an elementary school was quite exciting. What we did there is the coalition was made up of teachers and students and then parents and community folks, and they adapted the materials from Lexington. And rather than doing it during the summer, they did it during the school year. In some cases, teachers organized opportunities for the kids through recess or even in the classroom. But we also worked with the phys ed personnel and community members who volunteered and came in and did things during times that they could be more active. So yes, you can do that. And then we had after-school activities, but all coordinated through the school with a lot of help from like the YMCA and folks that work with the school closely.
Okay. All right. I think we will move on to Dr. Carlson's presentation, and then we will have time at the end for questions specific to his presentation, as well as some additional time for questions at large. Dr. Carlson.
Great. Thank you for that introduction. Hopefully my slides are presenting okay. So I'm going to be presenting results from two reviews that we conducted on supporting children's physical activity in elementary schools. So here's just a brief outline of what I'll be going over. So first, I'm going to cover our identification and assessment of state-level physical activity policies. And then I'm going to talk about some of the recommendations that were made during interviews that we did with State Department of Education, physical education and physical activity coordinators. And then finally, I'm going to talk about some evidence-based strategies that we identified for increasing physical activity during school. And so the first parts of my presentation will be particularly relevant to decision makers And then as I progress, I'll be covering some things that will be especially important to practitioners as well. And so a little background on school physical activity. Numerous health organizations recommend that elementary schools provide children with physical activity opportunities. Specifically, recommendations are for schools to provide at least 30 minutes per day of physical activity, at least 150 minutes per week of PE. That's in elementary schools. In secondary schools, it's at least 225 minutes per week of PE. And it's recommended that at least 50% of PE time be spent physically active. And also in elementary schools, it's recommended that they provide at least 20 minutes per day of recess and at least 30 minutes per day of physical activity and after-school programs.
We're going to launch your poll now, if that's okay.
Great. So now we'll launch the first poll. And I'll continue with my presentation while you respond to the poll.
Mm-hmm.
Why is it important to study policies? Policies are important for school-based physical activity because they set standards for schools to follow. They show commitment on behalf of policymakers. They provide accountability for schools to meet child health guidelines. Also, policies related to academic performance have a long history, while physical activity-related policies are recently becoming more common.
And for your poll results real quick, we'll let you know what we have here.
Great.
20 to 40%, we have 82% poll results for the 20 to 40%. Research studies have found children are typically physically active for what % of the PE lesson time? And almost all of our participants are in your first category of 20 to 40%, 18% in the 40 to 60, and 0 in your 60 to 80%.
Excellent. And so this first study that I'm going to be talking about was the one that was published in the Journal of School Health issue, and that involved identifying and assessing state policies, and we assessed them for their strength and specificity. And the policies that were included in this study could be a state statute or a Department of Education code that was bound by law. And we focused on policies requiring a specific amount of physical activity for schools to provide. So the two types of policies that were included either require a specific number of minutes of physical activity during school or a specific % of PE time to be spent physically active. And so, as you all know, based on the poll question, the reason that policies on % of PE spent physically active are important is because it's not unusual for children to be physically active for 30 to 40% of PE time, or even less in some cases. So I wanted to point out that we did not assess policies on PE requirements, such as minutes of PE, because these have been covered in other studies, and most states have these types of policies. So we just focused on minutes or % of PE time in physical activity. And so here are a couple examples of state policies that were included in our study. So this is a Washington, D.C. code. And it states that it shall be the goal of the District of Columbia for children to engage in physical activity for 60 minutes each day. Another example of the other type of policy that was included was from D.C. also, and it states that at least 50% of physical education class time shall be devoted to actual physical activity, with as much class time as possible spent in moderate to vigorous activity. And so I think now I will send out my other poll, and this is asking about the states that you are living in. And I'll continue on with my presentation while you respond to that poll. And so here are some of the results from the policies that we identified. We found that 15 states had a policy specifying minutes of physical activity during school, but as the red line shows in this graph, only 11 states had a policy that specified at least 30 minutes per day or 150 minutes per week of physical activity, which is the recommended amount. So I'm only graphing those 11 states here. And then, as you can see in the blue line, only 5 states had a policy that specified at least 50% of PE time in physical activity. So these policies are relatively new, and you can see that for the blue line, all of these policies have been adapted or adopted in the past 7 years or so. So these are fairly recently adopted policies.
We're going to share the poll results with you now.
Great.
Does your state require schools to provide children with opportunities to be physically active 30 or more minutes during school? And 55% said yes, 30% said no, and 15% said don't know.
Great. And so if you're interested in what your state's policy is, or if it was included in this study, I do have a list of the states at the very end of the slideshow. I'm not going to go over it, but it's a list of the states that are presented in this graph and with some details about the policy requirements. The overall takeaway message from this graph is that we've seen an increase in state policies on school physical activity in the past decade, but the number of states having these policies is still low. And so next, we rated these policies as weak, moderate, or strong based on the strength and specificity of the policy language. And so here's an explanation of how we derived the ratings. A weak policy included vague or confusing language and had clear loopholes. A moderate policy had language that was mostly clear with fewer loopholes. And a strong policy needed to contain language on implementation and monitoring or reporting. So using this rating system, our results were that 75% of the policies were rated as poor because they included vague or confusing language, and the other 25% of the policies were rated as moderate or adequate. We did not rate any policies as strong because no policies included language on implementation or monitoring. What we did next was we contacted the Department of Education staff, either the PE or physical activity or wellness coordinator for that state, to gauge, and we did an interview with them to gauge the monitoring and implementation of these policies. And we just contacted the states that had a policy that we assessed. And I'll just present some of the main findings, but the results from the interviews were that only 15% of the states did provide funding specifically allocated for implementation of their policy. And the funding in these 15% of the states, though, was only to disadvantaged schools. The level of implementation at the school level was generally unknown by the state level coordinator, and the only monitoring that the coordinator did consisted of school self-reports. So in some states, schools were reporting whether or not they were meeting the guidelines. However, the state level coordinator said that it was unclear how many schools were actually meeting the mandate because level of implementation was generally unknown. And the only monitoring, as I mentioned, consisted of self-reports. And so what we did is we asked these PE coordinators to make recommendations for policies and strategies for supporting children's physical activity. So I'll go over some of these recommendations, and these are things that are relevant to decision makers as well as practitioners at the school level. And so the recommendations are to require more time in PE, require PE teachers to be certified, require a minimum amount of physical activity in PE, and require physical activity in the classroom. Require schools to provide structured activity opportunities during recess, and then some things like requiring consequences for noncompliance of meeting policy guidelines. Require schools to appoint a PE or physical activity coordinator at the school or district level, and identify sources for funding, particularly in lower income schools. And then there were also recommendations to make PE waivers harder to obtain, and even to create policies at the federal level. And so we concluded, based on these findings, that although several states had adopted laws over the past decade that adhere to national school physical activity recommendations, essentially none provided monitoring, accountability, or funding for these laws. We also concluded that adopting policies to support physical activity in schools seems promising based on previous studies, but implementation plans, monitoring, and accountability are likely needed for these policies to be effective. And I think I have one final poll at this time. And I'm going to move on and just talk briefly about another study. I'm going to show you some preliminary results from another school physical activity study that we can. In this study, we looked at how existing practices at schools that schools were engaged in were related to students' physical activity. So this is different from the earlier presentations, as in we did not do an intervention. We just assessed the current practices that schools were already engaging in. And we found that the 5 most important practices that schools were using were having a PE teacher, providing at least 100 minutes of PE per week, having a staff or volunteer supervise recess, that's rather than a classroom teacher supervising recess, and providing at least 20 minutes per session of recess, and also having recess supervisors encourage and support physical activity. So those are the 5 most important practices we identified. And we measured children's physical activity objectively with accelerometer devices. And we looked at how these 5 practices were related to children's physical activity during school. And we found that children at schools that had 4 of the 5 practices had almost twice as much physical activity during school as children at schools that had only 0 or 1 of these 5 practices. And you can also see that over 10% of the 97 schools that we studied were implementing 4 of the 5 practices, and children at these schools obtained more than the recommended 30 minutes of physical activity per day during school. So that's represented by the green line in the graph.
We have your full results.
Great.
Thank you. Okay. For the answers, PE was 21%, recess 26%, classroom physical activity 4%, before after-school programs 13%, walking, biking to school 5%.
Mm-hmm. So what those poll results suggest to me is that all of those settings might be good opportunities for increasing physical activity. The audience was pretty evenly distributed across each of those different settings. So kind of my conclusion would be to focus on multiple settings. And here's some of our conclusions from this study, were that schools need to adopt a package of physical activity supportive practices. And as I mentioned, the fact that some schools were implementing 4 of the 5 strategies shows that this is feasible in some schools to implement multiple strategies. However, I want to acknowledge that lower SES schools were typically implementing fewer strategies, and children at these schools obtained fewer minutes of physical activity. So it's important that lower income schools receive more support and even funding for increasing physical activity. And so that's it for my presentation. I just want to point out some links to more information on these studies. The first link here is to a 1-page brief report on the state policy study that I just presented. And then the second link is a link to the actual policies. So I put all those together in a document if you're interested in reading those state policies. And regarding the second study that I presented, where we objectively measured the children's physical activity, we are working on a brief report that should be ready soon. And so if you're interested in those findings, you can contact me and I can send that to you. And so now I think I have time for a few questions. And also to point out again, here are the list of states that were covered in the policy study on the last two slides. I believe you have access to those, so I'll leave this slide up while we field some questions.
Okay, thank you, Dr. Carlson. That was really interesting. I have a couple questions. This is Dr. Jan. So while we're waiting for questions from the audience, so I noticed that DC in a couple of your slides seems to have a pretty sound and high requirements for physical activity, but also is one of the locations that has the highest rates of childhood obesity. So I was wondering did you look at and find a correlation between the sort of rigor of the policy and the extent to which they're dealing with childhood obesity as a problem?
That's not something that we explicitly looked at. I think that's a good question. So maybe one thought is that since these policies have been adopted so recently, maybe part of the reason was to combat childhood obesity in areas where it was a major problem. I think that's a good point.
Okay. Another question about waivers from PE. What were the nature of the kinds of waivers that were considered potentially, should not have existed really for getting out of physical activity?
I don't know as much about different types of waivers. When I talked with the state level PE coordinators, basically what they told me is that in some states and in some schools, waivers are extremely easy to obtain, and sometimes a high percent of the children are receiving waivers, and they did not feel that that was appropriate. And so, I mean, waivers can be obtained for different things, such as disability, physical functioning, and religious status and things like that. And they didn't mention any particular reasons for waivers that should not be granted, but just that so many waivers should not be given, and that in some cases way too many are currently being given.
I don't know if this is something that you accounted for or not, but often in elementary schools, health classes are during the time that would be otherwise designated for physical education. Did that play a role here at all? So sitting down and learning about health.
Okay. So that would be more relevant to the second study that we conducted, and we didn't assess health classes. So these were elementary school age children, and they're just reporting to us on average how much PE that they obtain. So you're right, it could be the case where sometimes PE is being supplemented for a health class, but I guess the other side of the argument would be that even if children are learning about health, that if they're sitting in a desk and not getting their 30 minutes a day of physical activity, that schools might not really be meeting their health needs.
Here's a question from the audience. Have you ever heard of the walking classroom, a 5th grade Common Core standard-based arts program that has students walk while listening to lessons for 20 to 30 minutes each day?
Yeah, I think that sounds like a great strategy for increasing physical activity. So that's incorporating physical activity into a regular classroom that otherwise would be sedentary, and they're still learning, and you're still able to do your lesson plan. So I think that sounds like a great opportunity, and there are other ideas like that as well, where you can incorporate physical activity into different types of classroom lessons. Thanks for sharing that.
Here's one more question from the audience. how have states obtained additional funding to support the PE requirement?
Yeah. That's a really good question. It was only a couple of states that had funding, and it was primarily for low-income schools. And so those were different types of grants that were applied for. And I can't remember exactly what types of grants they were. I believe in one state it was actually some people at the university, maybe university researchers, that obtained some grant money and supported PE in some low-income schools in a couple of communities. And I think maybe in another state it was more of a state-level grant that was obtained. And I don't have the details on how to identify those, but I think that that's a really good question, something to keep your eyes out for.
We have a couple more questions, but I also just want to open up the chat box to questions for any of the panelists. While we're doing that, I'll go ahead and ask a couple more questions of Dr. Karls. So there's a question from the audience. How do you recommend handling that children who do not achieve the appropriate test scores are not able to take PE due to need for additional curriculum time?
Well, one way to look at it is that there is a lot of evidence that suggests and shows that physical activity can actually lead to better academic performance. So there's maybe something about getting out of the classroom or expending that energy during a physical activity session that then leads children to actually do better on academics. So one thought is that you might actually be able to use physical activity as one way to maybe see some improvements in test scores. And I think another side of the coin is that it's a matter of kind of making. It's a tough decision, I think, is the other thing. So it's trying to figure out what's best for the student.
Okay, another question is, did you see any anecdotal examples of states where there was, or even locales where there was enforcement of some of these policies, even if there wasn't particular funding for enforcement or implementation?
From the interviews that I conducted, I did not hear that any states were really enforcing policies. There were some states that were really doing very little and even support the policy, and there were some states that were doing more to support the policy, like providing technical assistance and trainings and things like that. But as far as monitoring and enforcement goes, that really wasn't happening. And the monitoring, as I mentioned, was kind of the schools doing self-reports, just kind of a yes or no, or are you meeting the policy type of thing. And so it was pretty rare for the schools to report non-adherence. And even if they were, the state level coordinator didn't really see their job as being an enforcer. They were more interested in trying to support schools to meet the guidelines.
Does every state have a physical education coordinator?
Now, all the states that I contacted had someone. So it was either a physical education coordinator. Sometimes they're called physical activity coordinators. So they're not just specific to PE. And then in a couple cases, it was a wellness coordinator who I was talking to, who's in charge of more things than just physical activity and PE.
So in general, was this kind of a full-time job, or was this something added on to existing job description?
It seemed like it was a full-time job. And yeah, so they have one person at the state level.
All right, well, we're getting a few more questions for people in general. So I'm going to turn back to Dr. Bryant. There are a couple additional questions about the Activate for Kids as well that I'll try to answer in a few minutes.
Okay.
Hold on, I'm organizing my questions here for a second. Okay, I think I actually had already asked you the additional question, Dr. Bryant, that came for you.
That's fine.
There was a question about, oh, so how, Dr. Carlson, how do you account for so much variation at the state level? What's your hunch about why that is?
I think that's a good question, maybe a tough question to answer. Some states that I talked to, they really, maybe the state has more of what they call local enforcement, where they don't have as many state level policies in general, and they focus more on policies like city and county and maybe school district policies. So there's different levels of policies. So maybe one state that doesn't have these policies might have several school districts that have really good policies. I think one problem with that, though, is that it could show a lack of commitment by the state if they don't have the policy, and then some school districts might get left out and their policies aren't as good. Now, some people have, some of the state level coordinators I talked to even recommended level policies. So states and federal level and district levels, kind of different people think that the policies should be at different levels. And I wouldn't necessarily argue that one level is better than another, but more just that these policies are important because they are at least a starting point for some accountability and commitment and things like that. But just a policy in and of itself isn't enough, that you really need some mechanisms for implementing and monitoring these policies.
Okay, thank you. Dr. Bryant, the audience is asking you to comment on the social marketing piece and where you see it really going and enhancing our ability to address childhood obesity.
Well, I'm not sure how much this is just my personal interest evolving and how much of it reflects public health's new emphasis on policy development. But I really see many social marketers now shifting upstream to look at ways to influence what Dr. Carlton just talked about, and that's policy change in schools and in communities. So it's my hope that we can use these tools now to really get policymakers to look at the issues differently and adopt them where we're, and I think part of why we're stuck now, frankly, is that as public health professionals, we see the world through a public health lens. The first and foremost benefit we promise anybody is reducing some vague risk of some awful disease that's going to happen a long, long time from now. And people have so many immediate needs. You know, deep-seated fears are today, and they're often very, very different than just public health issues. So a really good motivation to get people active, for example, is how they look. And so for policymakers, we've got to get inside their heads and think, what makes them adopt something? And they are there representing us because they care, for sure. But they care about a lot of stuff, not just health. They care right now, of course, about the economy and many other things. So I see social marketing helping us in school health and in many aspects of public health to realize we really need to get outside of just our agenda and see the world as full of many, many more values and interests, and start listening more and maybe talking less before we're going to really be able to fight this.
Okay. I'm just going to take 1 minute to quickly answer a couple questions that came up about the Activate for Kids program. Somebody is asking about which states were the 6 southern districts in, and they were in 2 in each of the 3 states, Georgia, Florida, and Texas. We did promise confidentiality, so we're not disclosing the actual district that was involved. And there was also a question about how we evaluated socioeconomic status. And there's a table in the paper that discusses the % of eligible students for free or reduced lunch, and it varied between 35% and 60% across the 6 school districts. I think we have a couple closing comments at this point, and we should wrap up right on time, I hope. Thank you very, very much, though, to the panelists. Thank you.
Thank you, Dr. Jan. Thank you to our wonderful presenters and our partners at the United Health Foundation. You all will be receiving an email with a survey for your continuing education units. Excuse me, and a recording of this webinar will be available within the next day or 2, and you can find that on our website, which is ashaweb.org. And we hope that you'll join us for part 2 of our webinar, and we sure hope to see you in Myrtle Beach. Thank you very much, everyone.
Thank you, Jeannie.
Okay, have a good afternoon, and stay tuned for the webinar as well as the more details on these and other research going on in the Journal of School Health. Thank you.